This excellent medical student-led podcast is for educational purposes only and not intended to be used as...
Welcome back, everyone. This is episode 6, and we have some exciting news. It's going to be the first time we're expanding who's helping out with the podcast. With that being said, I'd like to introduce Brinda Ryali.
Hey, everyone. I'm Brinda. Excited to be a part of this podcast. I'm a Med-Peds intern, new to Chicago. Just exploring the city. It's been fun.
I was lucky enough to meet Brinda as part of my MICU elective. We got to work together, and then we crossed paths again during my sub. I'm now on the CCU. And she was super excited to help out. So she's actually going to lead today's case. We also have 2 new discussants with us. I'll let them introduce themselves.
Hey everybody, my name is Diego Valenzuela. I'm a 4th-year medical student. I'm interested in internal medicine, maybe doing a fellowship in critical care or nephrology. I'm doing a nephrology rotation right now that I really enjoy. So.
Hey everyone, my name is John Levinson. I'm a 4th-year medical student here at Rush. I'm going to be applying into internal medicine this fall. Potentially interested in maybe cardiology or GI. I'm currently at an inflammatory bowel disease rotation at Chicago, which I'm really enjoying. Glad to be here.
All right, guys, ready to get things started?
Let's roll.
All right. So your first aliquot. So you have a 69-year-old Caucasian male who presents to the ED with 1-day history of worsening shortness of breath and a 2-month history of fevers, 15-pound weight loss, and a dry, non-productive cough. So follow you from here.
So right away, just jumping into this, I think I have like 2 etiologies of where this could be. I'm either thinking of something like an infectious etiology or some kind of malignancy, especially with the weight loss and fevers and everything. What do you think, Diego?
Yeah, I agree. I mean, that's like a good way to start. Potentially maybe something autoimmune as well, but certainly infection.
That's awesome. So I think those are like the top 3 things we think of, right? When we see some non-specific symptoms with fever, weight loss, and this cough. So I think you hit it: malignancy, autoimmune, and infectious. So one thing that I've seen for a schema for fevers is IMAID. So, and you covered those. So like infection, malignancy, autoimmune, drugs, and endocrine. And then the other thing that I like to think about with weight loss is kind of breaking it up into, is it like in the setting of an inflammatory process or like a non-inflammatory process? So what would you think you would see in like a non-inflammatory causes of like weight loss? So you kind of hit the inflammatory stuff.
I mean, it could be intentional weight loss at start, or it could even be functional, where maybe they have some kind of functional GI issue, some kind of small bowel obstruction, or just maybe even some kind of nausea going on, such a brain process causing nausea.
Mm-hmm.
I think you guys nailed the big 3 on the head. Yeah. Just right on, common things being common. It's probably going to be something in real life. It's going to be something under one of those 3. When I first saw this, I'm seeing there's something happening in the background, like 2-month chronic picture. Mm-hmm. Then this worsening shortness of breath in 1 day. That sounds like it's the real reason this patient presented. Mm-hmm. Ready to move to aliquot 2?
Let's do it. So some more additional history for you. His past medical history is significant for a 30-pack-year smoking history, hypertension, hyperlipidemia, COPD, and chronic sinusitis. Does this change kind of where this is leading you?
Not really for me. I mean, the smoking and the chronic sinusitis, COPD, those all kind of direct me towards down the path of malignancy or infectious.
Yeah, exactly. I guess thinking I'm in the same mindset, because it's just a lot of the COPD exacerbations are caused by infectious etiology, and also obviously with smoking, you're getting some kind of lung cancer.
Awesome. So I think Kevin touched on this earlier, but kind of with this acute on chronic process, what do you think is kind of causing the more acute presentation? You touched on a little bit with COPD exacerbation, but what else can cause these acute symptoms?
I mean, you could think of like a pneumonia. It's an infectious thing.
An upper respiratory infection like the flu, or depending on what time this was, COVID, anything like that.
Yeah. Mm-hmm. I think those are all great, and mindful to keep like the clinical course. Tempo of disease is like super important to keep in mind when thinking about this. And we really didn't give you much here. Mm-hmm. So it's not surprising it doesn't change all that much, but let's see what aliquot 3 does.
Okay, so on further talking to the patient, he reports new onset substernal chest pain and also reports that he has not urinated for the past day.
I mean, with the chest pain, the shortness of breath could be like an anginal equivalent. So maybe he's having some sort of like cardiac process going on. He just hasn't really manifested much.
In the urination, it depends. Well, it goes hand in hand with weight loss. He may not be eating a lot or drinking a lot because he's not feeling well.
Yeah.
It could be part of it. You could also, I guess, in the past days. So again, it's something acute. So it really just points more to something in acute setting going on. And I think the substernal chest pain could be related to some kind of process in the lungs. Never know. Maybe there's an infectious component to it with the heart. Maybe some pericarditis, something involved. But
I think you really nailed it on the head. Like picking up the clues in this kind of suggests that it is something more acute, but also like keeping in the back of your mind that there is this chronic picture still going on. But right, like hasn't urinated in one day now, that's something's happening, right? And then keeping in mind that we have a complaint of shortness of breath, and now we're finding out some more information. Maybe it's chest pain. Are the two mutually exclusive, or is one causing the other? We'll find out. But kind of dissecting that already, it's really cool to hear.
Yeah, absolutely. So I know you said for that he hasn't urinated in the past year, thinking maybe like decreased PO intake, but what are some other things that can kind of cause decreased urine output? What's on your mind?
Just things that come up. You can have like an obstructive type picture, like BPH, but that kind of especially with the acute setting, doesn't seem necessary as likely. And he so far hasn't complained of any other symptoms. I would put it like of any kind of prostatitis type picture or anything like that. Could also just be some kind of acute kidney injury like hypovolemic AKI, which could kind of put in the picture I was saying earlier with the just not drinking enough water and everything like that could just lead to that.
Yeah, kind of like what John was saying, and the fact that I'm on renal, like I think of the AKI stuff. So like hypovolemia, maybe he's retaining this fluid because he needs to get his blood pressure up. Poor PO intake. It also could be an obstruction. We don't know. Maybe he's got new kidney stone. He's a 69-year-old male, I believe, and maybe he has some element of BPH, and maybe this is just a tipping point. But who knows? It could be pre-renal, intrinsic, post-renal, or something completely else.
Yeah, the one less I just had, maybe it could be a sign of some kind of metastasis to somewhere around like the urethra or the bladder or kidney, anywhere around there. So that's my only other thought I have on that.
That was awesome. You hit all the kind of big three things we classify into, right? So like pre-renal, intrinsic, and then post-renal. And like they were thinking of BPH given his age, but then also tying that in with the systemic symptoms we saw earlier and thinking maybe a malignancy that has metastasized. So those are all great thoughts.
Yeah, great job, guys. And we have limited data right now. Like we have no vitals, no lab data, and we're already clued into like this. Is this an AKI? And I'm just thinking because I reviewed it recently, but like the criteria for AKI are mostly creatinine related, but the third one is decreased urine output, like 0.5 cc's per kg or per hour. But we're keeping that in mind already.
So we finally have some more data for you guys. So on physical exam, he has a temperature of 101.3, blood pressure 100/64, heart rate of 110, respiratory rate 20, saturating at 94% on room air. His lungs were clear to auscultation in all lung fields. His heart sounds were regular rhythm, tachycardic, but no murmurs were noted. And then palpable purpura on the dorsal surfaces of his bilateral feet are noted.
Purpura, that's kind of interesting, kind of points to the picture on vasculitis is something that kind of just came up when we think of the autoimmune type picture. And then especially with the decreased renal output, maybe that's kind of involving the kidneys. You could think of things, something I was thinking about earlier, but I thought was too much of a zebra was with the sinusitis. You could have Wegener's, which that ties all three together. We're going to have the nose, the lungs, and the kidneys involved. And to go that, I actually had a patient with that. It's a pretty terrible and debilitating disease. So it's also unusual for his age to kind of have it in like, what was he, 70?
Yeah, 69.
69. But that's something that's kind of just come into my mind.
Yeah, I agree with John. Like he has signs of like upper and lower respiratory tract involvement, which are, signs of possible like Wegener's. And given a fever, maybe he has a flare going on right now, and maybe he's had it forever. He just does, or for a while, he just doesn't realize. But I still think it's important to like think about infection and stuff, given he's got a fever, his vitals are just unstable, and I also thinking whenever I see palpable purpura, I always think of like that one disease in kids, like Henoch, Schoenheim purpura. So I always think of that too, but I highly adds that. That's just like the classic step one buzzword. So.
And also on top of that, the patient I did have, she had the Wegener's caused chronic damage in the lungs, which then led to her having aspergilloma. So there's always, you could have the chronic issue of like the autoimmune disease weakening and leading to an infection there. I guess the lungs are cleared auscultation in all fields. So maybe it's not some obviously clear, huge lobar pneumonia or something, but it's something to keep on the radar when at this point you can't rule out infection, especially with a fever 101.3.
I like to pose this question: sick or not sick?
Sick.
He's definitely sick, yeah.
And how does the temperature change your guys' thinking? We've kind of touched on it a little bit, but I'm just wondering, like, now if we go back to aliquot 1 and we talked about those 3 buckets, how does the temperature fit in?
Brother, it's definitely high enough. Like, if you start at fever 100.4 and this is almost a full degree above that, you definitely got to be thinking some kind of virulent organism going on to cause the fever to go up that high, especially with his heart rate being up to 110 and his O2 sat being down to 94% and just on room air, not just sitting in a hospital bed.
I mean, we've already touched on it, but palpable purpura is a very unique finding, right? When I first saw this, I'm trying to think of what I would think of if I saw that on findings. We've touched on vasculitides. I'm wondering if you guys, just out of curiosity, like, what else comes to mind with palpable purpura?
I think of like a hemolytic disease, some sort of like some form of autoimmune, like, like anemia, as you mentioned, vasculitides. I'm not sure if it happens with malignancy, but I feel like those would be like the main things. Some sort of problem with, maybe also some problem with the liver as well, because you've just got, extravasating blood. So that's something I think of.
No, it's perfect. I like to think about it in like coagulopathy versus like vascular issues. So that was perfect.
Love where this is headed, guys. Great reasoning so far. Let's go to aliquot 5.
All right. So we got some labs for you. So CBC is remarkable for a white blood cell count of 18, hemoglobin 9.2, platelets of 455. CMP is remarkable for a creatinine of 15, BUN of 200, potassium 6.6, bicarb 16. The ESR was elevated at 92. Your UA showed hematuria and proteinuria. Troponin was elevated at 1.3, and EKG showed ST elevation and leads 2-3 AVF concerning inferior wall MI. So I know there's a lot here, so we can slowly pick this apart.
Yeah.
I'll start with one thing at a time. So we'll start with the CBC, just looking at that with the platelets being 455, like thinking some kind of like, thrombocytopenia maybe causing, that's more fatigue than purpura, but I think that's kind of out. The white count being up, I think that kind of ties in more with the infectious etiology. CMP, creatinine 15. So that's something seriously going on. Because I remember talking to one of my attendings, if he was telling me if I took and cut your ureters right now for 24 hours, your creatinine will go up to 2 in one day. So 15 is something serious is going on with the kidney. So that's like definitely this has been a chronic issue. The kidney to really go up that high, especially potassium 6.6.
Yeah.
ESR of 92, infectious or autoimmune, hematuria and proteinuria. Kind of like the thing that jumped off of me was again the Wagner's. I don't know if it's kind of a zebra diagnosis for this, but because it does have a mixed picture of both. And then the inferior wall MI is interesting because that might be in the case of almost like a demand cause.
Yeah.
Potentially coming in with just being sick and everything like that. If he has like, chronic coronary artery disease and you're sick and you're not able to perfuse that well enough. But I don't know, with ST elevations, it seems kind of severe.
Let's pull off a quick aside here.
Yeah, sure.
Being that we're both on the CCU right now, we talk about this at rounds all the time. Does ST elevation localize to a particular vessel?
And more, I feel like localizes to like a particular region of the heart, or the wall, surrounding the heart. But I wouldn't say it's like it's this vessel versus another one. It's like, well, it could be this one, it could be another one. We don't know exactly.
Totally a loaded question on my part.
Okay.
It totally depends on like their coronary anatomy.
Yeah.
But something I learned that I didn't realize is ST depression like says something ischemic is going on, but you can't interpret like if there was depression in 2-3 in AVF, we can't really say that's inferior. Just an aside there. All right, Diego, I'm going to pose this to you.
Okay.
Given this data now, and you're the doc in charge, what are you doing next?
Yeah, so for him, I see that the main things that jumped off the page for me were creatinine of 15, BUN of 200, potassium 6.6, bicarb of 16. So I'm thinking he's got some sort of metabolic acidosis going on right now. And considering he has like a little bit of high troponin and ST elevations, I want to go to lactate on this guy to see if he's like ischemic or not, because that'll like change my management in terms of anion gap, metabolic acidosis or non-anion gap. That'll be the first thing. And the second thing was the UA showing hematuria and proteinuria. I definitely want to like see how much proteinuria that is.
Yeah.
Because, you know, as John mentioned, like if we're going to go down the like a glomerular or like the vasculitis thing, like there's always a component, there might be a component of glomerulonephritis, so, or nephrosis. So, you know, just checking to see how much proteinuria that can rule out a nephrosis syndrome or, you know, rule it in kind of thing. So.
And then the one thing, I guess he's got a STEMI, and one thing's like, oh, I want to take him to the cath lab,
Yeah.
but he's a creatinine of 15.
Yeah.
So, I mean, that's kind of, it's an acute renal failure. It's,
Can you give him contrast,
I
right?
think, I guess they could do dialysis afterwards. In a setting with STEMI, I think it would be important to try to,
It becomes a benefits risk thing.
yeah, if he's having acute STEMI, I guess.
Well, you got that angio.
So coronary angiography did not reveal any atherosclerotic lesions and no stents replaced. So does this kind of rule anything out for you? Does it change what your top differential is?
I think he's got like some sort of vasospastic thing going on. I don't know. I just kind of like the whole like picture thing. I think of like a Prinzmetal angina kind of thing going on. I don't know, but just because there's no lesions, but he's got like this ST elevation and he's got all these other like kind of systemic things going on. I think it's just, I don't know, just kind of drags me towards that way. Because I feel like I've seen that in test questions before. Like, I don't know how to describe it, but
No, that's a great thought. Yeah.
Beautiful reasoning. You just identified like a unique bucket of normal coronary angio STEMI.
yeah.
What else can cause troponin elevations? Let's talk about that.
That's
Mhm.
yeah.
Well, yeah, so a lot of different things, especially since we recently here switched to high sensitivity troponins, we've seen it. So it doesn't necessarily mean you're having a heart attack. There's some kind of stressor on the heart going on. And that could be from a lot of things, hypovolemia. You can even have like myocarditis, pericarditis type picture. Just really a lot. Like if you're just putting demand on the heart, you're sick, it's tachycardia can really do it. So he already has a heart rate of what, 110?
Yeah.
He's been losing a lot of weight. It's just not necessarily just has to be an MI.
Yeah, and I know there's like types of MIs. I can't remember all of them off the top of my head, but or like STEMIs, but you know, I've seen in the past like people with elevated troponins due to like hypervolemia. Like, you know, it's all depends on like the Frank Starling curve, where they're at on that curve. You know, maybe they're being overloaded and their heart, you know, maybe their EF isn't that great, so they just can't pump as well, so they need to take some fluid off, or maybe there's not enough, so it's just like trying to pump more. It's more of like a demand, and like it doesn't have enough blood to pump as well. So yeah, I mean, there's a lot of other reasons besides like intrinsic damage, like from a plaque causing ischemia to the heart. But
there's also with his renal, like he's obviously in renal failure,
Yeah.
and you know, just patients who are on dialysis often have elevated troponins. And there's kind of a multifactorial thing of like not just one, they're not able to clear the troponin like a normal person too. And there's also theories behind it where just being in that state of renal failure just causes stress on the heart itself, just elevating the troponins because they have it high at baseline for another person.
yeah, cardiorenal.
Cardiorenal. You guys are nailing this
Yeah.
incredible reason. So fun. I like got goosebumps on my arm.
You said everything I was hoping you would say.
Okay,
That was
good.
perfect.
Okay,
Yeah.
good.
What you guys were saying reminded me, like, we know an elevated troponin can be due to many different things, but kind of synthesizing that in the clinical picture. Like if someone has an elevated troponin in the setting of crushing chest pain, we're going to give that more validity than if it's someone not complaining of any chest pain and just it was a random troponin check, right?
Mhm.
Let's move on to the next aliquot.
Let's do it. All right. So we have some imaging for you now. So CT chest was unremarkable, no nodules, no focal consolidations, but you get CT paranasal sinuses, and that shows severe diffuse paranasal sinus disease and severe thinning or absence of the cribriform plate. Get an autoimmune workup. Your ANA, rheumatoid factor, and anti-MPO were negative. And your anti-proteinase 3, so your C-ANCA, was elevated at 32. I know you guys have been kind of getting to this point, but I'll let you take it from here.
Yeah, so C-ANCA is, I believe that's associated with Weckner's because I kind of remember the C. That's how I remember for step one, because it's you kind of tied all the three organs and it kind of explains all the symptoms going on, especially I wrote like it's really destructive of like the nasal septum and everything that you're seeing here. And those are like the whenever I rotate on ENT, they just said there's like the most difficult like rhinoplasties they have to do. So yeah, with the C-ANCA, that's really seems to be where it's pointing. Yeah, do you have anything, Diego?
Yeah, I agree. There's a couple of diseases that have like elevated C-ANCA. I know it's not just Wegener's. I know there's like a scenic eosinophilic polyangiitis as well. Something else I can't remember, but I think like those are the main three things we should be thinking of if we see this.
No, that's perfect. Those are like vasculitis is the number one thing you think of when you get a C-ANCA.
Mhm.
What else might cause like an elevated C-ANCA outside of vasculitis?
I feel like I remember seeing one. I think it's ulcerative colitis might cause it as well. And
Yeah, I think, yeah, it's with that and PSC. I think it's
Yeah.
Bianca. I can't
Okay.
remember one of the two, but yeah, they're associated with each other. But anyways, yeah, definitely.
You guys take stuff yesterday or
Yeah.
something?
No, that was incredible. That was exactly what I was going for. The only other one I was gonna add is sometimes with like bacterial, like infective endocarditis, like you
Yeah.
can get an elevated C-ANCA, but absolutely like the number one things you think of are vasculitis.
They're markers, they're neutrophilic markers.
Yeah.
Right? So like the endocarditis, I recently heard this too and was totally surprised, but it makes sense. Like if you have a super infectious thing going on, your neutrophils are ramping up. It's not all that surprising that it will come back elevated too.
Does it surprise you that the CT chest is unremarkable?
It doesn't surprise me because I know you can have like pulmonary hemorrhage. If I'm gonna commit to saying like it's a vasculitis disease, like I know you can see pulmonary hemorrhage with these, but you don't have to have it. It's more of like and he could have possibly presented with that because he was tachycardic, anemic, maybe he was having like an ongoing hemorrhage, but if he's not, it's a great thing that he's not, that it is negative. So it kind of doesn't make us want to have to go take him to like get a thrombectomy or something like that immediately.
I'm gonna challenge you guys.
Go for it.
What are you gonna do next? What are you gonna do to confirm diagnosis? Do you start treatment?
I think you should get a kidney biopsy just in general, but I think with the way how sick he is, I guess trying to think the last thing we could blood cultures and want to do that, see if he's any sepsis. You got to identify that. I don't think GPA explains all of the symptoms that show how acutely ill he is, where I want to feel if we hit him with the treatment cyclophosphamide, right? So that's gonna if he's got an infection, it's gonna go crazy and go everywhere. And that's not a benign drug either. So so I want to try to find a source of infection and then try to get a targeted therapy for that. So then maybe potentially we can then treat the GPA.
Yeah.
Are there certain symptoms that don't fit into your schema for Wegener's or like granulomatosis or polyangiitis?
I mean, like the urinary retention or oliguria, I feel like you'd have some, urination. So, but maybe because his creatinine is so bad. But I'd still want to get like an ultrasound of his bladder just to make sure that there's no obstruction, because if there is and we miss that, it's a really bad thing to miss.
That's an easy thing to check.
Exactly,
right?
exactly. And just do a bladder scan, just like a bedside. But yeah, I mean, that's like probably one of the main things that I'm just like, I usually don't see this. But like Don mentioned, like a kidney biopsy would be helpful to like rule that in.
Oh, sorry. I was also want to do maybe a quick echo to look for any like regional wall abnormalities of the heart, because maybe with maybe a PE could kind of be involved with what's going on. We can even go to CTA, but see what's going on with that.
I like everything you guys have said, and I'm gonna keep challenging you guys because why not? Let's go back to this potential STEMI.
Mm-hmm.
Does that fit into the direction we're heading now?
I think it's from because I have the patient. I think I could be wrong, but I think cardiac involvement can happen, but it's rare. But it could be. I don't know. Like, I'm not sure. Maybe just like how acutely ill they are, and maybe it could even be like pulmonary embolism, some kind of along that route be causing that potentially. I know it's not like the classic, the S1 T3 that you see with PE, but I guess you can cause right heart strains, which you're looking for when you're looking for like with a massive PE or submassive criteria. But yeah.
Going back to the presenting complaint. So this patient came in with acute worsening of shortness of breath.
Mm-hmm.
So knowing everything you know right now, what do you think was the cause of that acute worsening of his shortness of breath?
I think it's still trying to find some kind of infectious etiology, because it may not just be a pneumonia, but it could be some kind of other like sepsis, or it could have some kind of like, bladder or UTI or anything like that, or pyelo, or maybe even, I think still want to rule out PE.
Yeah, I kind of agree with John. I also totally forgot to keep my derm control was like, because we're seeing all these systemic things, was amyloidosis. I feel like that like causes a lot of things. I know it can cause like a lot of heart problems as well. It can go just many years without nobody would know they have it. And I was gonna say lupus, but his ANA is negative, so it like kind of brings that down my differential, but and rheumatoid factor, but
Yeah, you could do that in the echo too.
yeah, exactly. You could,
And so
yeah, you could test for that. So
You guys have covered so much, and what I love most is you've kind of kept the frame of everything going on in mind and have kept your differential broad, but discussed why things don't fit. And I have a feeling I know where both of you are headed. We have a little bit more information to give you.
okay.
All right, so the patient was initiated on CVVH for acute renal failure and empiric treatment for the presumed diagnosis. So biopsies were obtained prior to initiating treatment. So I got punch biopsies of the skin lesion on the dorsal surface of his feet that showed leukocytoclastic vasculitis. And kidney biopsy showed posse-immune focal segmental necrotizing incresentic glomerulonephritis with secondary acute tubular necrosis. So I think you guys have the diagnosis and you've had for a while, but
Yeah.
what are y'all thinking?
go GPA. Okay, which is the other name for Wagner's grant.
Yeah.
Yeah.
Yeah, I agree with John. It's just interesting, like he's got like secondary, it sounds like he's got FSGS from that description. I just, I don't know. I know it's like can be due to a GPA, but there's also like other causes as well, like drug abuse, infections like HIV, Hep B, Hep C. So, you know, just trying to see, or maybe getting those serologies and tests later on would be helpful to make sure, you know, this is not something else like that we're missing that maybe he's had for a while that we just don't know. But yeah, I mean, I agree with like the starting him on dialysis because he really needs it, and just interesting.
Yeah.
Interesting patient.
That was great. I really wanted to talk about causes of FSGS, so I'm glad you brought that up. Yeah, step ahead.
I also just want to mention, like, from that, I can tell Diego's a pick'em dictum guy, not Occam's razor.
Yeah.
But yeah, let's talk about FSGS because you're on renal right now.
Mhm.
What are some of the causes? You mentioned a couple. I'm trying to remember what I associate with that
Yeah.
too.
I think I remember heroin as a cause, heroin use. I remember Hep B, Hep C, HIV.
I think sickle cell was too.
Yeah, sickle cell. There's actually a lot more causes than I thought. I thought it was like just one or two things, but I know there's like some medications as well. Actually, crazy thing is I believe research is saying that COVID is a potential cause of FSGS, like secondary FSGS. And there's like, it's, you can see it in like different areas too. Like, so there's like grades of FSGS, like certain parts of the glomeruli can be affected. And so I think COVID is like one of the worst because it affects the hilum, which is like where, like that's, you know, where that's the entire base of the glomerulus gets infected or gets impacted. So I just know that's bad. It's not great to have FSGS. It's really not good for you, but unfortunately, that sounds like he's got it.
All right, let's put your nickel down. What's the final diagnosis and how are you treating it?
GPA, and then you gotta do cyclophosphamide, and we still want to, I guess, we talked about the cultures, try to identify an infectious sort before we start treatment and rule out infection. Yeah,
I agree. I think it's GPA. It also does start like steroids, just to get down some of this inflammation that's going on everywhere. I mean, you know, in the heart, kidneys, like maybe he's got something, I mean, in his nasal passages or nasal canals as well. So I think that would definitely help, like a stress dose of the steroids.
You guys were spot on. I think you got to it at like aliquot 3 or 3 or 4.
Wow.
You guys were on top of it. That was wonderful. So yes, it is granulomatosis with polyangiitis. The patient was treated with the methylprednisolone pulse therapy and then was followed by cyclophosphamide and prednisone. But I have no words. At like aliquot 3.
I had a patient with it, so I guess that helped. It was just like when I saw the sinusitis, I was like, oh, maybe. I'm like, that's too much of a zebra, and then I was like, oh, actually, this might be it.
It's interesting that he got this at like 69 and
Yeah.
or 70 years old and he had never had this before. It's kind of scary to think that you could still get stuff like this that late.
Yeah, with IBD, which is the rotation on now, there's like a bimodal presentation of it. You can get it like in your 20s and you can get it in your 50s to 70s. I've seen a number of patients who just started getting in their 60s. Wow.
So what do you know about the epidemiology of GPA? Like what's the like patient presentation you think of?
I feel like it's like a female, like in their, I don't know, middle age that I know it's like, I mean, it's an autoimmune disease or
Yeah.
pretty much. So I feel like it's always mainly females that present with it, and coming in with like hemoptysis, like epistaxis, like shortness of breath, cough. Yeah, exactly. Blood from basically all the orifices.
My illness script, I'm for some reason associating this one being more associated with males. and I'm not-
Is it really?
I think it's like
I don't know.
50s to 70s, male, usually Caucasian. But you're right that like usually with autoimmune, you immediately
you always-
think like
yeah,
female.
Yeah, I'm glad.
So,
glad I heard that.
you know,
Before we go into some teaching points for GPA, I just want to acknowledge that we refer to it as Wegener's disease throughout the episode and recognize and understand that there's a push to have that name changed formally to granulomatosis with polyangiitis due to Dr. Wegener's questionable knowledge of practice and association with the Nazi Party. We'll be mindful using the GPA name going forward.
And everything going on. That's one thing where I'm kind of confused on, but I guess that
Appreciating the pathophysiologic difference between vasculitis and vasculopathy will frame your thought process. Vasculopathy is the narrowing and eventual occlusion of the vessel due to thrombosis, septic emboli, or intravascular protein deposition, whereas vasculitis becomes a narrowing and eventually occluded vessel due to the inflammation in the actual vessel wall and subsequent endothelial proliferation. So there are many vasculitides and it's challenging to keep track of them. So a helpful organized approach is to first characterize them based off the size of the vessel that they typically affect. And then for the small vessel vasculitis in particular, whether or not they are ANCA or immune complex associated. So there's numerous overlapping similarities between the vasculitides. It can be helpful to prime your mind with characteristic or differentiating features and pivot points when you suspect a vasculitis picture. I'll try to highlight those as we work through the schema. So the large vessel vasculitis are giant cell or temporal arteritis, which affects the major aortic branches, can have clinical features including headache, scalp and jaw pain, jaw claudication, or amaurosis fugax when it involves the ophthalmic artery. 50% of patients with GCA or temporal arteritis have associated polymyalgia rheumatica. The other large vessel vasculitis is Takayasu's arteritis. It's very similar to GCA, but it more commonly involves the aorta, subclavian, or common carotid. And a differentiating feature with this one is limb involvement with a clinical sign of limb claudication. The medium vessel vasculitides include polyarteritis nodosa, which can present as mononeuritis multiplex, levato-reticularis. It can have nodules or ulcerations. There's often renal involvement. And then GI involvement, which would include a clinical picture suggestive of mesenteric ischemia. Another medium vessel vasculitis includes primary angiitis of the CNS. The difference here is that there's isolated CNS involvement, so there's a classic triad of headache, altered mental status, and then new focal neurological deficits. Kawasaki's disease is another medium vessel vasculitis. It's thought to be due to infection or an abnormal immune response to infection, and it's primarily seen in children under the age of 5. I turn to the crash and burn mnemonic when thinking of this. So it's characterized by conjunctivitis, a desquamative rash, the strawberry tongue or mucositis, and then erythema and edema of the hands and feet. Additionally, a very high fever of usually greater than 5 days. Last are the small vessel vasculitis. And first, I break them up into ANCA associated, which includes granulomatosis with polyangiitis. It's typically C-ANCA positive, anti-PR3 positive. It's posse immune, causes necrotizing granulomas. And I like to think of the letter C, which includes ENT, pulmonary, and renal involvement. So if we were to draw a C on a body, it helps capture all 3 of those. Microscopic polyangiitis is another small vessel ANCA associated. It's P-ANCA positive and anti-NPO positive. It's non-granulomatous, typically only involving the lungs and kidney. And then lastly is eosinophilic granulomatous with polyangiitis. The clinical picture is often a person with asthma and nasal polyps. It's P-ANCA and anti-MPO associated. And then, as the name indicates, eosinophilia is characteristic. It often involves neuro, pulmonary, and cardiac systems. Last are the small vessel immune complex associated vasculitis, which includes cryoglobulonemic vasculitis. Can be seen in the setting of multiple myeloma, hepatitis C, lupus, Sjogren's. Rheumatoid factor is often positive, and there's a very low C4. Palpable purpura are a common skin finding. IgA vasculitis or HSP, often seen in the setting of a viral URI or strep pharyngitis. Features include abdominal pain, GI bleed, arthritis, arthralgia, and glomerular nephritis. And then lastly is hypersensitivity vasculitis, which is the last of the immune complex associated. And unique to this is it's often isolated cutaneous involvement is the only clinical picture.
As reasoning, I think we can just go over some teaching points for GPA.
Yeah.
We have some here that Brinda will lead us through, but please, like, John, you've already seen a case. Diego, you were already on top of this too. Like, throw in your pearls too.
Yeah, absolutely. I feel like you both have touched on a lot of this already, which is great. But like we talked about, affects the small and medium vessels. So patients initially present with very non-specific symptoms, kind of like what we saw with this patient, right? So you get like weight loss, fevers, night sweats, arthralgias, and you can go down like any schema, right? Like infectious, malignancy. So it makes the early diagnosis really difficult. You also get like insidious onset of like ENT symptoms. So exactly like you said, I know you thought it was a zebra, but like that chronic sinusitis, like you want to think about vasculitis, right? Especially GPA, because that's initially patients can have it for like months to years before they have any of these more serious systemic symptoms, and where you get like renal failure and you get like a myocarditis or myocardial infarction. So it's good to think about vasculitis with ENT, like chronic ENT symptoms. So a positive C-ANCA, you like 100% think of GPA, right? But like you said, John, you want to get that tissue biopsy. I think it's clinician dependent on like whether you want to start treatment before you actually get that diagnosis. And it's like part of it is how sick is the patient, right? Like you said, this patient was really sick. And you both asked for a lot of like infectious workup that actually came back negative on this patient. We didn't include it in all the aliquots. So absolutely, depending on the clinical picture, you would start it before you get biopsy confirmation, but obviously you would get the actual biopsy before you start any of the treatment. What else? You went through the differential, so I won't spend a lot of time, but like we said, thinking about malignancy, infectious processes, sarcoidosis, and then all the other different vasculitis that you can have. And then the most important thing, the reason it's a zebra and it's rare, but the reason we want to keep it on our differential is it really changes like the mortality rate once you start treatment, right? So without adequate treatment, 1-year survival is less than 20%, but the 5-year survival with adequate treatment is about 80%. So it's really important to diagnose it early and start treatment. And this patient was pretty lucky. He came off of CVVH, went on HE, went home to didn't go home, but he went to like acute rehab and did fairly well given his clinical presentation.
Wow. Anything you guys want to add? Some stuff you've seen or heard along the way?
Like the patient I had, it's non-specific symptoms, was actually, she just, she was unable to take her medications for a few months prior to her hospitalization. She kind of just presented with increased shortness of breath. And just eventually went into acute respiratory failure. I actually thought it was initially a panic attack at first because she was getting so anxious for being in the hospital. I actually tried to sit down and watch like Friends with her to try to see if that made her feel better. And then it kept going on for a few hours. So it was a little bit too long and she had to be intubated for a while. And then they actually gave her IVIG and she got much better. Oh, wow. So it was that was an interesting case.
The patient previously had a diagnosis of GP and had a.
Yeah. One of the differences, I think I was talking, my dad's a pulmonologist, I was curious about it. I was talking about afterwards, like, panic attack or some like acute respiratory issue. She was desatting on nasal cannula down to like 83, 88. And she kept saying, I'm anxious. It's my anxiety. So that's one of the things I was trying to see if I could help with that to get the underlying cause. But apparently with panic attacks, he says usually they're not going to desat as acutely as that.
Yeah.
So I mean, keep in mind, I guess.
Another thing I learned in kind of reviewing for this discussion is the lung findings are awful in this.
Yeah.
It's like capillaritis, interstitial lung disease, and then the worst case is diffuse alveolar hemorrhage. Fortunately, it sounds like this guy with a normal chest CT, lung involvement wasn't significant, and hopefully it stays that way being on treatment. But just keeping that in mind too, this could progress rapidly and cause some pretty devastating processes.
Yeah, one thing I learned just because on the rotation on renal, we've seen patients with this, is that once they're diagnosed and they're getting treated and stuff like that as an outpatient, they'll come in with flares like occasionally, but to check for flares, you just get another C-ANCA level because that can actually become negative like while they're not having a flare, So you kind of just check that if you think they're having a flare, they're coming into the office, or they were sent in from the office to the hospital to be admitted. You should check that because it can change from negative to positive, and that will indicate to you that they're likely having a flare. And I didn't know that at all. I thought it always stayed positive forever.
I didn't know that either.
So it was good to.
That
was a good pearl.
That's a great pearl.
On that note, guys, thanks John and Diego for coming on, being discussants. Very brave of you, and you guys wish you were on. You're welcome back anytime. You're master clinicians in your own part already. It's kind of crazy to think about thinking if you were an M1 sitting in this seat and what 3 years has done already. And then thanks to Brinda for joining the team and leading us in a case. We're really looking forward to having her, and just thanks again.
Thank you. You guys did a great job. You're going to be great I&amp interns. And Kevin, thanks for having me on the podcast. Been a great sub-I. So.
And then one more thing before we sign off, I forgot to say in the beginning, Dr. Abrams is with us. He's listening, but he's on service, and the realities of the job are that things come up and he had to be pulled away, but he was here listening, and he'll be back next time, I'm sure. So on that note, keep it alert and oriented.